Hi, my name is Neil Anglem, and today I'm going to talk to you about the assessment of a patient who presents with dyspnea and peripheral edema. So, what is dyspnea? Dyspnea is a feeling of breathlessness and sometimes a discomfort in the chest due to breathing issues. And peripheral edema is simply fluid accumulation in the extremities, usually the legs, but can also be seen in the arms and hands. So when somebody presents with peripheral edema and shortness of breath, this can be, from a cardiologist's perspective, this can be a sign typically of heart failure. There are many different causes of heart failure. The top causes being that of ischemic heart disease, hypertension, valvular heart disease, cardiomyopathy. Chronic lung disease can cause cor pulmonale, pulmonary embolus, and pulmonary hypertension. That's mainly the cardiac causes and why a cardiologist would be involved. However, being a cardiologist and assessing somebody with shortness of breath, we need to make sure we don't miss any non-cardiac causes of breathlessness. We can split the differential of breathlessness into cardiac, respiratory, and non-cardiac causes. However, respiratory causes include COPD or asthma, chest infections or pneumonia, or pulmonary embolus, which would usually also present with a pleuritic type chest pain. Systemic causes include anemia, metabolic acidosis, anxiety, and hyperventilation. When considering peripheral edema, we've again previously mentioned cardiac causes causing heart failure, but again, cardiac heart failure, valvular heart disease, and pericardial effusion or constriction can also present as peripheral edema. Non-cardiac causes of peripheral edema include renal causes, including nephrotic syndrome, chronic kidney disease, hepatic causes such as liver cirrhosis and portal hypertension, and other causes include venous insufficiency, lymphedema, and medication side effects such as the use of calcium channel blockers. So when somebody presents with acute shortness of breath and or peripheral edema, you want to approach the patient with an ABC approach, so check the airway, breathing, and circulation. For the airway, look in the mouth, make sure there's no obstruction there. Breathing, you would assess the respiratory rate, listen to the lungs, and check the oxygen saturations. And circulation, check the pulse, blood pressure, check the capillary refill. Now, if we go on and take a history of a patient that is breathless, you want to ask a few specific questions. You want to find out when the onset was. Did it suddenly come on, or has the breathlessness been gradually building up? And what kind of restrictions do they have with the breathing? Is it that they can't walk? Are they breathless at rest, or they cannot walk just down a few paces? Or is it more, are they breathless when they're walking up hills? Are there any other associated symptoms such as a cough, fever, chest pain? Is there a heaviness in their chest when they're, for example, walking, which could be angina rather than anything respiratory or lung related? Is there anything that makes the breathlessness worse? Is there anything that relieves it? Do they have any past medical history that may point towards a diagnosis, such as do they have a history of previous myocardial infarction or cardiomyopathy, or do they have a history of asthma or COPD? And when it comes to the peripheral edema, you want to know, did the legs, for example, suddenly become swollen? Is it unilateral, bilateral? Is it associated with any pain or any other symptoms such as a fever or redness in the skin? Is it made worse late? Is it seen to be worse later on in the day, or is it first thing in the morning? The peripheral edema is non-existent, which would be suggested of dependent edema. And again, you want to know if they have any other past medical history. They're known to have a history of heart disease or heart failure. They're known to have liver disease or kidney disease, which may be contributing to the peripheral edema. So on examination, you want to start with an inspection, first of all, and then followed by a full cardiovascular and respiratory examination. You just want to start off by looking at them. Do they have any evidence of a barrel chest or kyphoscoliosis, which may be impairing their breathing? Are they using accessory muscles to breathe? Are they pale looking, or are they cyanotic? If you take a look at their hands, is there any evidence of clubbing? What is their capillary refill like? Do they have any peripheral cyanosis? You want to check their pulse. Are they tachycardic? As arrhythmias can also contribute to breathlessness and signs and symptoms of heart failure. Is their JVP raised? Also, when you move on to the full cardiovascular examination, you want to check the apex beat. Is it displaced? When auscultating the heart, are there any obvious murmurs? Or the heart sounds muffled, which may suggest pericardial effusion, which again can contribute to breathlessness. On the respiratory examination, you want to know, is the trachea deviated? Is there equal lung expansion? On percussion, is there stony dull percussion or hyperresonance? Hyperresonance and tracheal deviation may suggest a pneumothorax. When listening, Is there any crackles, fine inspiratory crackles, coarse inspiratory crackles? Are there bronchial breath sounds? Is there an expiratory wheeze? This may help, or putting all this together will help make a differential diagnosis. When examining the limbs, is there evidence of peripheral edema, pitting edema, or is there any edema in the arms or abdomen? Are there signs of any chronic liver disease, the spider nevi? Is there a yellow tinge or jaundice to the skin? Once we've done a full examination, we then want to think about what further tests are required to investigate the dyspnea and peripheral edema. So initial tests include blood tests, which include a full blood count. And the full blood count you can look at the hemoglobin to see if there's any evidence of anemia. You can look at the white cell count to see if there's any evidence of infection. From a user needs perspective, you can see if there's an acute deterioration in the renal function. Check the liver function tests to see if there's any evidence of abnormal liver function, which may contribute to peripheral edema. An NT-proBNP may be useful if assessing specifically for heart failure and fluid retention. You'd also want to get an ECG performed. Again, specifically, as previously mentioned, there could be an arrhythmia that may be contributing to breathlessness, or there may be evidence on the ECG of a previous myocardial infarction. A chest X-ray is extremely useful in order to assess the lung fields and the heart size. Chest X-ray will often reveal if there's any consolidation or a pneumothorax, or any evidence of pulmonary edema. Depending on your differential from the initial investigations, you then may want to go on to further, more specific investigations. For example, if you're expecting a cardiomyopathy of any sort, then an echocardiogram would assess the heart structure and function, including valvular pathology. A CT scan of the chest will also look further into the lungs. Other tests you may want to consider are arterial blood gases, a 6-minute walk test, and peak flow. In conclusion, therefore, a patient who presents with dyspnea and peripheral edema has a wide range of differential diagnosis. From a cardiac perspective, one of the top diagnoses is one of heart failure, and obviously there are different causes that can cause the heart failure, but please don't forget there are other causes of peripheral edema and shortness of breath which need to also be excluded. Thank you very much, and if you want to get notified of future videos from me, then please click the subscribe and notification bell to receive these updates. Thank you very much.